one-sentence summary, this paper presents a computational Bayesian model for predicting Alzheimer's disease by correlating various biomarkers to provide early diagnosis through a user-friendly web platform that supports medical professionals in assessing the risk of Alzheimer's development. 2. Purpose of the study: address the complexity of Alzheimer's diagnosis. Recognize the multifaceted nature of symptoms, types, and progression of Alzheimer's disease, highlighting the need for sophisticated diagnostic tools. Improve early diagnosis, stress the importance of early detection in managing Alzheimer's, given the limitations of current treatments and the progressive nature of the disease. Integrate Bayesian methods in medical decision systems. Utilize Bayesian statistics and Markov chain Monte Carlo methods to develop a robust diagnostic tool that can predict Alzheimer's disease progression based on biomarker analysis. Necessity of the study: lack of effective treatments. Current therapeutic strategies are mostly ineffective in reversing Alzheimer's, thus emphasizing the need for better diagnostic approaches. Variability in clinical presentation. The disease's diverse manifestations necessitate a versatile diagnostic tool that can handle different data types and provide personalized outputs. Early intervention potential. Detecting the disease at an early stage can significantly impact the management and planning of care, potentially slowing the progression. 3. Subject, method, and results. Subject. The study focuses on developing a Bayesian model for Alzheimer's prediction that evaluates the association of various biomarkers with the progression and presence of the disease. Method. Utilizes a Bayesian statistical approach implemented via the Winbug software, incorporating a user-friendly web interface for inputting biomarker data and generating disease probability statistics. Results. The Bayesian model effectively integrates multiple biomarkers to predict Alzheimer's disease risk, providing probabilistic outputs that can inform clinical decisions, showcased through various example scenarios demonstrating the model's utility in hypothetical case studies. 4. Conclusion and follow-up research. Implications. The study demonstrates the feasibility of using a Bayesian approach to enhance Alzheimer's diagnostics, proposing a method that can adapt to new biomarkers and integrate diverse data types for a more accurate prediction. Follow-up research plans. Researchers suggest the creation of an open biological database to collect and share biomarker data, which would help in refining and validating the diagnostic model. 3 additional follow-up research directions. Validation against clinical outcomes. Conduct studies to compare the model's predictions with actual clinical outcomes to verify its accuracy and reliability. Integration of new biomarkers. Continuously update and expand the model to include emerging biomarkers and genetic data that could improve predictive accuracy. Development of similar models for other neurodegenerative diseases. Apply the Bayesian approach to develop diagnostic tools for related conditions like Parkinson's disease or frontotemporal dementia, leveraging the framework established for Alzheimer's disease prediction. Novelty, most important finding. The most significant novelty of the paper is the development of a computational Bayesian model that integrates a variety of Alzheimer's disease biomarkers to create a probabilistic medical diagnostic tool. This tool not only predicts the likelihood of disease development, but does so through a user-friendly web interface, making it accessible for medical professionals to input biomarker data and receive real-time prognostic information. The use of Bayesian statistics combined with Markov chain Monte Carlo methods for Alzheimer's prediction represents an innovative approach, particularly in how it handles the complexities and variabilities of the disease symptoms and progression. Suggested keywords: 1. Alzheimer's disease. 2. Bayesian statistics. Biomarkers. Early diagnosis, 5. Markov chain Monte Carlo, 6. Medical decision systems, 7. Computational model, 8. Neurodegenerative diseases, 9. Probabilistic diagnostics, 10. Winbug software. Concept explanation, Bayesian statistics versus frequentist statistics. Bayesian statistics and frequentist statistics are two fundamental approaches to statistical inference, each with distinct philosophies and methodologies. Bayesian statistics. It uses probability to represent uncertainty about all aspects of a statistical model, including both data and parameters. Bayesian methods update the probability estimates as more evidence, data becomes available, using Bayes' theorem. This approach allows for incorporating prior knowledge or beliefs into the statistical model, which are then updated with new data. Frequentist statistics. This approach relies on the idea of long-run frequencies of events to define probabilities. It does not incorporate or update probabilities based on new data. Instead, it estimates parameters based on sample data by optimizing certain criteria like likelihood. Frequentists interpret probabilities only in terms of long-run frequencies of repeatable events. Here's a summary table comparing the two. Aspect, Bayesian statistics, frequentists of long-run frequency. Probability treats probability as a measure of belief or certainty. Defines probability in terms of long-run frequency. Prior information incorporates prior knowledge through prior distributions. Does not use prior information. Inference updates beliefs with new data using Bayes' theorem. Relies on sampling distributions without updating beliefs. Interpretation. Probabilities are subjective and updated over time. Probabilities are objective and fixed. Common tools. Bayes' theorem, posterior distributions, confidence intervals, hypothesis testing, Tashard rationale of using Bayesian method. The rationale for using the Bayesian method in this paper is primarily due to its strength in handling uncertainty and incorporating prior knowledge about Alzheimer's disease biomarkers. This approach is particularly effective for integrating varied data types. Bayesian methods can seamlessly integrate different types of data, e.g. clinical, genetic, behavioral, into a unified statistical model. Handling complete data, it provides a robust framework for making inferences from incomplete data sets, which is common in medical research. Updating information. As new biomarker data becomes available, the Bayesian model can update its predictions, making it extremely useful for ongoing clinical assessments. Personalized medicine. The probabilistic nature of Bayesian inference supports personalized diagnostics and treatment plans based on individual biomarker profiles. Questions and answers for comprehension assessment. 1. What is the main purpose of developing the Bayesian model in this study? Answer. To predict Alzheimer's disease development and progression by integrating various biomarkers into a probabilistic model that updates its predictions as new data becomes available. 2. How does Bayesian statistics differ from frequentist statistics in this context? Answer. Bayesian statistics allows for the incorporation of prior knowledge and continuous updating of disease probability as new biomarker data is entered, unlike frequentist statistics, which would not update probabilities with new data. 3. What role does the Winbugs software play in this research? Winbugs is used to implement the Bayesian statistical model, facilitating complex probabilistic calculations and simulations needed for the model's predictions. 4. Why is early diagnosis of Alzheimer's considered critical, according to the paper? Answer. Early diagnosis allows for the potential management and treatment of the disease before significant brain damage occurs, possibly slowing disease progression. 5. Can you describe an example scenario provided in the paper for using the Bayesian model? Answer. One example scenario involves inputting biomarker data into the web interface developed alongside the Bayesian model to receive predictions about Alzheimer's disease likelihood and progression, helping clinicians make informed decisions. In the context of Alzheimer's disease prediction and diagnosis using biomarkers, deep learning and machine learning techniques provide powerful alternatives to Bayesian statistics due to their ability to handle large data sets and learn complex patterns without explicit programming for each variable interaction. Here's a recommendation for a machine learning method that could be beneficial. Recommended method: convolutional neural networks, CNNs, for image analysis. Convolutional neural networks, CNNs, are particularly useful in medical imaging analysis, which can complement biomarker data in Alzheimer's disease research. MRI and PET scans are commonly used to observe brain structure and function in Alzheimer's patients. CNNs can automatically detect patterns and anomalies in these images that might indicate the presence or progression of the disease. Title of a relevant previous study. One relevant study that utilized CNNs for Alzheimer's disease is 3D convolutional neural networks for diagnosis of Alzheimer's disease via MRI and PET-T by authors in a 2018 publication. This study explored the use of 3D CNNs to analyze MRI and PET images, achieving high accuracy in distinguishing between Alzheimer's patients and healthy controls. The CNN model learned to identify subtle patterns in brain images that are indicative of Alzheimer's, which might not be easily noticeable by human observers. Additional machine learning approach: support vector machines, SVMs. Support vector machines, SVMs, are another machine learning technique that could be effectively used in Alzheimer's disease prediction, particularly when dealing with structured data like biomarker profiles. SVMs are excellent for classification tasks and can be used to classify patients into different categories based on the progression and type of Alzheimer's disease, based on their biomarker data. Integration suggestion: combining CNNs with traditional biomarker analysis through an integrated machine learning model could lead to more robust predictions. Features extracted from imaging data using CNNs can be combined with biomarker data to feed into an SVM, or a multi-layer perceptron, MLP, providing a comprehensive overview of both structural changes in the brain and biochemical markers. This multimodal approach can enhance the accuracy and reliability of Alzheimer's disease predictions. Such integrated approaches harness the strengths of both imaging analyses through deep learning and traditional biomarker analyses, potentially leading to significant advancements in early diagnosis and the monitoring of Alzheimer's disease progression. As a strict reviewer of a scientific journal, I would provide the following critique of the article on the Bayesian model for predicting and diagnosing Alzheimer's disease. Critique of the article. 1. Clarity and depth of the model description. The article presents a computational Bayesian model. However, the description of the model could be more detailed regarding its implementation and the specific Bayesian techniques used, e.g., specifics of the prior distributions and the convergence diagnostics. A deeper explanation on how the model handles different types of biomarkers and integrates them could enhance understanding and reproducibility. 2. Validation of the model. The paper discusses the model's capabilities through hypothetical scenarios, but lacks real-world data validation. For robust scientific credibility, it is crucial to present case studies or pilot testing results where the model has been applied to actual patient data and its predictions compared against clinical outcomes. 3. Comparison with existing methods. While the model is innovative, the paper does not sufficiently compare it to existing models or methods in neurodegenerative disease prediction. A comparative analysis with other statistical or machine learning models would provide a clearer view of the model's advantages or potential limitations. 4. Technical assumptions and limitations. Any assumptions made by the Bayesian model are not thoroughly discussed. Clarification of these assumptions and a discussion on the limitations they might impose on the model's applicability in diverse clinical settings would strengthen the paper. 5. Software accessibility and usability. The article mentions the development of a user-friendly web interface, but does not address issues of accessibility, scalability, or security, which are vital for clinical applications. Furthermore, details on the usability of this interface for non-technical medical professionals would be beneficial. Suggestions for introduction discussion additions. Introduction. 1. Historical context. The introduction could benefit from a brief history of Alzheimer's diagnostics and the evolution of predictive modeling in the field, setting the stage for the significance of the new Bayesian approach. 2. Review of biomarkers. A more detailed review of the biomarkers used for Alzheimer's disease, discussing their roles and how they have been previously integrated into predictive models, could provide a stronger foundation for the relevance of the Bayesian model. Discussion. 1. Broader implications. The discussion could expand on how this model could influence future research directions in neurodegenerative diseases beyond Alzheimer's, potentially opening avenues in predictive diagnostics for related disorders. 2. Ethical considerations. Any predictive model in medicine brings ethical considerations, particularly concerning the prognosis of diseases like Alzheimer's. Discussion about the ethical implications of early diagnosis and the potential psychological impact on patients could be included. 3. Scalability and implementation. Discuss the scalability of the model when applied in larger, more heterogeneous populations. Also, consideration of the logistical and technical challenges in implementing such a model in routine clinical practice would provide a more comprehensive understanding of its utility. 4. Future enhancements. Suggestions for future enhancements of the model, such as integration with other machine learning techniques or real-time data updating, could be discussed. Mention how emerging technologies or future advancements in biomarker research could further improve the model. 5. Interdisciplinary collaboration. The discussion could advocate for increased collaboration between computational scientists, neurologists, and bioinformaticians to enhance the development and refinement of predictive models for Alzheimer's disease. These critiques and suggestions aim to enhance the manuscript's scientific rigor and contextual depth, potentially increasing its impact and applicability in the field of medical diagnostics for Alzheimer's disease. alternative explanations or interpretations of the results. The results presented in the paper are based on the application of a Bayesian model for predicting Alzheimer's disease. Here are a few alternative explanations or interpretations of these results. 1. Model overfitting. The Bayesian model may be overfitting to the specific set of biomarkers and data used in the simulations. This could result in high accuracy in model predictions within the controlled environment, but may not generalize well to real-world clinical data across different demographics or stages of Alzheimer's disease. 2. Impact of prior selection. The choice of priors in Bayesian analysis can significantly affect the outcomes. If the priors are too strong or not representative of the actual population characteristics, the model predictions could be biased toward these assumptions rather than reflecting the true nature of the data. 3. Influence of unmeasured confounders. There might be other underlying factors or confounders not included in the model that could influence the progression of Alzheimer's disease, such as lifestyle factors, environmental exposures, or genetic predispositions beyond the considered biomarkers. 4. Statistical noise versus significant prediction. Some of the predictive power demonstrated by the model could potentially be due to statistical noise rather than actual meaningful relationships between biomarkers and Alzheimer's disease progression. This could especially be the case if the model complexity was not adequately balanced with the noise level in the data. Follow-up research project. Title: Enhancing Alzheimer's Disease Prediction, Integration of Genetic Markers and Environmental Factors in a Bayesian Framework. Objective: to enhance the predictive accuracy and generalizability of the Bayesian model by integrating genetic markers and environmental factors alongside the existing biomarkers. Project details. 1. Data collection. Collect a large, diverse dataset including not only traditional biomarkers but also genetic data, e.g. APOE4 status, and environmental factors, e.g. exposure to pollutants, dietary habits, physical activity levels. Include participants from various ethnic backgrounds and age groups to ensure the model's applicability across different populations. 2. Model development. Develop an expanded Bayesian model that incorporates these new variables. Utilize machine learning techniques to select the most predictive features. Adjust the model to handle the increased complexity and potential interactions between biomarkers, genetic markers, and environmental factors. 3. Validation. Validate the model using both the original dataset and an independent validation set from a different population or geographic area. Employ cross-validation techniques to evaluate the model's robustness and ability to generalize. 4. Implementation of real-time learning. Implement a real-time learning system where the model can update its predictions based on new incoming data continually. This system would allow the model to adapt to new research findings and changes in patient condition over time. 5. Ethical and psychological considerations. Conduct a parallel study to assess the ethical implications and psychological impact of early predictive modeling on patients and their families. Develop guidelines for the responsible use of predictive information in clinical settings. 6. Outcomes and dissemination. Measure the impact of including genetic and environmental factors on the accuracy and clinical usefulness of the predictions. Publish the findings in peer-reviewed journals and present at international conferences. Create an open access web portal for other researchers to access the model and contribute data. Expected impact. This follow-up study aims to create a more accurate, robust, and ethically responsible model for predicting Alzheimer's disease, facilitating earlier and more personalized intervention strategies, which could potentially slow the progression of the disease or improve the quality of life for those affected. I'll provide a detailed outline of a research paper in the context of using machine learning techniques for Alzheimer's disease prediction. The paper will be structured as follows. Title: Advanced Machine Learning Approaches for Early Prediction of Alzheimer's Disease, Integrating Multimodal Biomarkers. Table of Contents. 1. Introduction. 2. Related research. 3. Research methodology. 4. Results. 5. Discussion and conclusion. 6. References. 1. Introduction. The introduction will outline the significance of early detection of Alzheimer's disease, AD, and the potential impact of machine learning in enhancing diagnostic protocols. This section will emphasize the complexity of AD, the limitations of current diagnostic methods, and the need for innovative approaches that leverage technology and big data. 2. Related research. This section will review existing studies focusing on various aspects of Alzheimer's prediction. Traditional diagnostic methods. Overview of clinical assessments and biomarker evaluations currently used. Machine learning models. Summary of recent research using machine learning and AI in predicting AD, highlighting studies that utilize neural networks, support vector machines, and other statistical learning methods. Multimodal approaches. Discussion on the integration of genetic, neuroimaging, and physiological data in predictive models. 3. Research methodology. Data collection. Description of the multimodal dataset including genetic markers, MRI, PET scans, and clinical biomarker data. Model development. Detailed methodology for the development of a hybrid machine learning model combining convolutional neural networks, CNNs, for image analysis and random forests for structured biomarker and genetic data. Validation techniques, explanation of cross-validation methods, and independent test sets used to evaluate the model's accuracy. 4. Results, model performance. Presentation of the model's performance metrics such as accuracy, sensitivity, specificity, and area under the Rossi curve. Feature importance. Analysis of the most predictive features within the model, highlighting which biomarkers and image features contribute most to accurate predictions. 5. Discussion and conclusion. Interpretation of results. Discussion on the implications of the findings for clinical practice and future research. Limitations. Critique of the study's limitations, including potential biases in the dataset and model overfitting. Future work. Suggestions for further research, including the potential for real-time adaptation of the model as new data becomes available. 6. References. This section will include a comprehensive list of all sources referenced throughout the paper. Citations will adhere to a specified academic style, typically APA or MLA, and will cover a range of sources including peer-reviewed journals, authoritative websites, and seminal books on machine learning and Alzheimer's research. Example references might include Alzheimer's Association, year, Alzheimer's disease facts and figures, journal name, volume pages. Smith, J. and Doe A. year, title of the study on AD prediction using CNN. Yan, Zhang Y. and Li K. title of the book on neural networks in healthcare. Example reference, Krzyzewski A., Sutskever I., and Hinton G. E., 2012, ImageNet classification with deep convolutional neural networks. Communications of the ACM 66, 8490. This outline will serve as a blueprint for a comprehensive paper detailing the use of advanced machine learning techniques in the early prediction of Alzheimer's disease. The references included in the actual paper will be accurately cited and relevant to the study's findings discussions. Alzheimer's disease treatment challenges, diversity of symptoms, complex diagnosis, asymptomatic cases, detection difficulties, sporadic and familial types, varied progression. Research focus, non-classic statistical evaluation, known Alzheimer's biomarkers, tool developed, computational Bayesian tool, WinBug software, probabilistic medical prognostic process. Functionality, web page for medical professionals, upload tests, receive statistics, track disease development or presence, abnormal biomarker testing. Keywords: early diagnosis, Bayesian statistics, medical decision systems, Markov chain Monte Carlo, Metropolis Hastings algorithm, WinBugs. Alzheimer's disease etiology, unclear etiology, recognized risk factors, early onset, disease progression, AD categorization, 8 categories, risk factors, symptoms, lesions, biomarker analysis, in-depth analysis, disease severity impact, symptomatic treatments, no holistic therapy, cholinesterase inhibitors, NMDA antagonists, beta secretase inhibitors, gang secretase inhibitors, A secretase stimulators, tau inhibitors, immunotherapy, nutraceuticals, nanodrugs. Key focus: early diagnosis, facilitate prediction and management. AD classification summary, prodromal AD, clinical symptoms, memory disorders, CSF biomarkers, AD dementia, social and daily life impairment, typical AD, progressive memory loss, cognitive disorders, atypical AD, aphasia, frontal atrophy, amyloidosis support, mixed AD, typical AD plus cerebrovascular Lewy bodies disease, preclinical states, in vivo amyloidosis, genetic mutation carriers, Alzheimer's pathology, senile plaques, neurofibrillary tangles, mild cognitive impairment, MCI, measurable MCI, no AD evidence. Bayesian network of AD biomarkers, genetic factors, APOE4, AP, PS1, TQ AD, prepathological markers, tau, amyloid beta, A-beta, typical AD, neurological impact, memory loss, hippocampal atrophy, atypical AD, neuropsychiatric symptoms, visual disorders, typical AD, metabolic dysregulation, unbalanced CA++, senile plaques, mixed lifestyle factors, smoking, obesity, physical activity, AD dementia, inflammatory processes, cytokines inflammation, AD pathology, mitochondrial dysfunction, mito MFN1, OPA1, prodromal AD, oxidative stress, isoprostanes, prodromal AD, daily functioning, day living activities, MCI. Bayesian statistics and sorrowful tool, biomedical informatics, medical decision systems, Markov chain Monte Carlo, MCMCMC, solution for disease evaluation, environmental assessments, satisfactory results, Bayesian mechanics, unknown parameters, random variables, prior distribution, posterior distribution, model calculation. Bayesian equation summary. Posterior distribution, that y, proportional to likelihood, y in state. Prior theta incorporates prior distribution plus observed data, y likelihood function, product of individual data points, y1, y2, yn, and probabilistic model for AD biomarkers, disease development, algorithmic approach, AD prediction, Winbug software, Bayesian inference, data analysis, experimental section, model description, data, examples. Bayesian approach summary, Bayes theorem, event probability AIB, random variable y, probabilistic path Fy theta, parameter vector sample y size, and events AB, composite event AI calculation. Bayes' theorem general form summary. Posterior, PAB, proportional to likelihood, PBA, with prior, normalized by. Bayesian inference and MCMC summary. Expectation E theta KY, integral of TK P theta Y T variance, integral of TK theta P theta Y, minus E K Y, function of parameters. Expectation and variance, posterior distribution P theta Y used in MCMC. MCMC methods summary. Metropolis-Hastings algorithm. Foundation of MCMC methods gives sampling. Special case of Metropolis-Hastings. Bayesian expert system Athanasiosa Model. Medical decision system. Dyspnea diagnosis. Bayesian networks BN for AD prediction model, directed graph G, nodes, paternal nodes, N, joint distribution, product of node probabilities, conditional on parental nodes. Bayesian model for AD prediction, biomarker abnormalities, AD prediction, clinical trials data, probability export, continuous refinement, categorical prior distribution, AD categories representation, acyclic graph, underlying biomarker severity, In the provided notation, R, simtext dcat, PE, we are looking at a statistical model expressed in the context of Bayesian networks or probabilistic programming. Here's what it means. R, this is a random variable that we are interested in. It represents a specific outcome or state that the model will predict or classify based on the probabilities provided. Sim. This symbol is read as distributed as and indicates that the variable on the left side of the symbol has a distribution described by the right side. Text dcat PE. This represents a categorical distribution denoted by dcat, which is a distribution over a finite number of possible outcomes, often used to model scenarios where an event can result in a fixed number of discrete outcomes or categories. The P inside the brackets represents a vector of probabilities associated with each category. Each entry in this probability vector corresponds to the probability of the respective category being the outcome. Together, this notation states that the random variable R follows a categorical distribution with a given set of probabilities for each possible category. In practical terms, if R were to represent a disease state, each category could correspond to a different stage of the disease, and the probabilities would quantify the likelihood of each stage occurring. This type of modeling is often used in Bayesian statistics for classification tasks, where the outcome is one of several discrete possibilities. AD biomarkers and probabilities, age factors, increased AD probability with older age, genetic markers ApoE4, APS1, 2, physiological changes, amyloid, tau proteins, lifestyle factors, smoking, obesity, physical activity, neuropathology, senile plaques, neurofibrillary tangles, cognitive symptoms, memory impairment, executive dysfunction, Probabilistic model summary. Initial probabilities set specific biomarkers, e.g. AP at 10%. Age factor, influential 85 years. Parent nodes probabilities, defined, e.g. Lewy bodies. Bayesian network structure, node connections based on disease mechanics. MCI validation probabilistic model, initializations at probability 15%, age factor 85, probability 0.01, true. Lewy bodies set to probabilistic values, metal ions, oxidative stress, inflammation, impact on prodromal AD, genetic factors, APOE4, PS1-2, influence on preclinical AD, cognitive impact, e.g. memory loss. Leads to MCI neuropsychiatric symptoms, e.g. tau, affect typical AD daily activities, strong indicator probability 1, true. Disease pathway, biomarker abnormalities, MCI development. Winbug's model initialization, parent knots, true initialization, probabilistic values assigned, indicate true state, child knots, binary false true state, Lewy bodies exception, difficult diagnosis, probability of false, true sequence for parents, all combinations for children. Add a probabilistic model structure, biomarker relations, multiple AD types, categorical variable nodes, DCAT, node linkages, single or multiple parents, model design, NCDS ADRD criteria, maximum probability export for each AD category. General model for AD variables, age, biomarkers. Categorical distribution. Biomarkers include ApoE4, A-tau, cytokines, metal ions, etc. Risk factors. Hypertension, depression, smoking, diabetes, obesity, physical activity. AD types. Prodromal, dementia, typical, atypical, mixed, preclinical. Condition dependencies. Max functions determine AD category based on biomarker levels. MCI detection is based on daily activities and other factors. Output. AD category probabilities based on Bayesian network calculations. Model extension and adaptation. Incorporate new biomarkers, adjust symptom and lesion relationships, update relative probabilities, align with international health protocols. Examples provided for abnormal biomarker tests indicating potential AD presence. MCI probability calculation, MCI given daily activities, high probability 0.999, condition age 85, daily activities abnormal, model output true for MCI node when daily activities are impaired. Winbug's data initialization summary. Variables set, age, metal ions, app, cytokines, daily activities, P53. Probabilities defined for age, genetic factors, lifestyle factors, biomarkers probability assignment. High, Lewy bodies, miRNAs, ApoE4 app. Moderate, metal ions, inflammation, tau. Low, hypertension, depression, smoking. Outcomes modeled, MCI strongly tied to daily activities impairment, probabilities adjusted, reflecting real-world data variability. Winbug's MCMC analysis summary, stochastic variables, interval categorization, positive values only, distribution, categorical, DCAT, MCMC output, posterior estimates, mean, SD, error. Iterations, 3000 and 1000, convergence on MCI mean value. Winbug's MCMC output for A categories. Prodromal 80, mean stable 1.56, 80 dementia, mean stable 1.50, typical 80, mean stable 1.5, atypical 8, mean constant 1.0, mixed 80, mean stable 1.56, preclinical states, mean stable 1.5, Alzheimer's pathology, mean constant 1.0, mild cognitive impairment MCI, mean high 2.0, standard deviation, low variation, decreases with more iterations. Alzheimer's disease probability from day living activities, prodromal 80, probability twice 0.56, probability 0.50, typical 80, probability twice 0.50, atypical 80, probability 0.0, mixed 80, probability 0.56, preclinical 80, probability 0.50, Alzheimer's pathology, probability 0.0, mild cognitive impairment, probability 1.0, stability of probability from 3,000 to 1,000 iterations is observed. MCI has a notably high probability, indicating a strong correlation with day living activities. Other categories maintain moderate probabilities, with atypical AD and Alzheimer's pathology showing no correlation. The equation shown appears to be calculating the expected value E for mild cognitive impairment, MCI, based on the probability of MCI given daily living activities, P MCI daily living activities. It simplifies the calculation by using the probability of MCI directly to find the expected value, which in this case is 0.999, indicating a very high likelihood of MCI when daily living activities are impaired. This equation represents a probability calculation using Bayes' theorem. It calculates the conditional probability of Alzheimer's disease pathology, AD pathology, given the presence of certain microRNAs, miRNAs. The result of this equation is 1.0, suggesting that within the context of this model, the presence of specific miRNAs is a definitive indicator of AD pathology. This could imply that in this hypothetical or model-based situation, the occurrence of these miRNAs always coincides with the disease pathology. Age 85 days, immunity mRNAs i T antibodies for tribals raised on for probabilistic values. When bugs input true, A's AD pathology probability equals 1. Probabilistic model, miRNA is a true 100% AD pathology validation. Winbugs results example 2, prodromal AD, preclinical states, moderate mean, some variability. AD dementia, typical AD, mixed AD, Alzheimer's pathology, high mean, low variability. Atypical, mild cognitive impairment, defined mean, no variability. mRNA's biomarker impact summary, AD dementia, typical AD, mixed AD, Alzheimer's pathology, probability 1.0, high impact, preclinical states, probability 0.5, moderate impact, atypical AD, mild cognitive impairment, probability 0.0, no impact. The provided information appears to be a data initialization list for a Bayesian model in Winbug software, commonly used for statistical analysis, particularly with complex models. Here's a brief keyword-oriented summary of the critical components. Variables: age inheritance, metal ions, AP, cytokines, daily activities, p53, each with binary states, 2 options. Prior probabilities, p.x, assigned to states indicating the likelihood before observing the data. Structures, data and dim, define the dimensions and interdependencies in the network, variables, interrelations. Key biomarkers, ApoE4, PS1, SOR2, tau phospho, miRNAs. Health factors, hypertension, depression, smoking, diabetes, obesity, physical activity. Pathological factors, senile, plaques, unbalanced CA, vascular issues. Biological measures, oxide stress, inflammation, isoprostanes, mitochondrial activity, mito. Genetic indicators, p53 miRNAs, cognitive functioning, daily activities, memory hippocampal loss. Outcomes, MCI, mild cognitive impairment, likelihood. This data is essential to simulate or estimate the probabilities of Alzheimer's disease categories or cognitive impairments based on various genetic, biological, and lifestyle factors. It looks like you've shared a detailed list of variables and their associated probabilities for a Bayesian network in Winbugs. I'll break down the key components in simplified terms. Variables like age inheritance and metal ions have 2 possible states, denoted by =2, which probably represent binary outcomes, e.g., presence or absence of a feature. Probabilities, p.x, are the prior probabilities assigned to each state of the variables. Structures with .data and .dim are likely defining the relationships between variables and their states, shaping the network's edges and how they influence one another. Variables like MCI due to day-living indicate a special interest in understanding the impact of daily living activities on the likelihood of mild cognitive impairment, MCI. These components are used to build a probabilistic model that helps estimate the likelihood of various Alzheimer's disease categories based on the presence or absence of certain biomarkers and risk factors. The structure allows for the combination of prior knowledge with observed data to infer the probability of outcomes like prodromal AD, AD dementia, and MCI. The image you've provided seems to be showing a mathematical expression related to a Bayesian statistical model used to calculate the mean value of Alzheimer's disease pathology, AD pathology, after a number of iterations, which is a common process in Markov chain Monte Carlo, MCMC simulations. The formula is calculating the expected value of AD pathology. The expected value, E AD pathology, is computed using the probability, P AD pathology. According to the given formula, E AD pathology equals 2 times P AD pathology plus 1 times minus P AD pathology. Given that the mean value is calculated to be 2, and since the expected value expression simplifies to 1 when P AD pathology is set to 1, it is inferred that P AD pathology is 1. The conclusion P AD pathology miRNAs equals 1 suggests that the presence of certain miRNAs, microRNAs, predicts the presence of AD pathology with certainty in the context of this model. This is a theoretical or model-based probability and would need empirical data to support such a strong conclusion in real-world scenarios. You've uploaded an image of a probabilistic model, which seems to be a Bayesian network visualizing the connections and conditional probabilities among various factors and biomarkers related to Alzheimer's disease. Given the nature of the model, certain nodes, biomarkers, have been initialized with strong probabilities pointing to a high likelihood of their association with different Alzheimer's disease categories. Here's a summarization with the key elements highlighted. App probability, 50%. Age 60, initializations of 0.57, true, 0.43, false. Lewy bodies, probability 0.884, false, 0.116, true. Strong biomarkers, tau, Aβ, APOE4, amyloid angiopathy set to 1, true. AD categories, prodromal AD, AD dementia, typical AD, mixed AD, preclinical AD, model focus, simultaneous evaluation of AD categories with specific biomarker probabilities. The Bayesian network uses these probabilities to evaluate the likelihood of AD presence or the stage of AD based on the true or false status of these biomarkers. This kind of model can be instrumental in understanding complex relationships and dependencies among various factors that contribute to the progression of Alzheimer's disease. The provided list seems to be initialization parameters for a Bayesian network model tailored to assess Alzheimer's disease AD risks based on various biomarkers. Here's a summary with emphasis on key parameters. Age inheritance, strong inclination towards no heredity, 0.57, false, 0.43 true. Metal ions, more likely normal, 0.76 false. AP, balanced influence, 0.50, 0.5. ApoE4, higher risk, 0.30 false, 0.7 true. Biomarkers tau phosphoso ABEPI miRNA set with certainty, 1 true. Vascular factors set to exhibit pathology, 1 true. Daily activities indicative of impairment, 1 true. Inflammatory markers, oxid stress, inflammation, isoprostanes all set with no issue, 1 false. Mitochondrial function, mito1, mito2, mito3. No dysfunction, 1 false. Cellular stress marker, P53, predominantly normal, 0.75 false. This summary outlines key probabilistic assignments within the model which contribute to evaluating the presence and type of Alzheimer's disease, focusing on the balance or likelihood of each factor being normal or indicative of disease. For the third case scenario, age 60, not a high risk factor, amyloid beta and tau proteins abnormalities present, age inheritance, and APE influential factors marked true. APOE4 significant risk determinant set as true. Vascular issues indicated as true within the model. This setup in the probabilistic model suggests a heightened concern for Alzheimer's disease due to the presence of key biomarkers and genetic inheritance factors, despite the individual being less than 60 years old. Comprehensive analysis. AD categories, risk assessments completed, high risk for AD presence, conclusive findings, amyloid beta and tau proteins, critical biomarkers, importance and effectiveness, notable in AD aggravation. These points encapsulate the impact of the amyloid beta and tau proteins on the advancement of Alzheimer's disease, with a substantial risk identified across various AD categories after extensive simulation. For a patient under 60 who is a smoker with obesity and depression, the Bayesian model estimates the probability of having either prodromal AD or mixed AD due to these risk factors to be 0.464. This suggests a moderate likelihood of AD presence based on the interplay of these conditions under the specified parameters and assumptions of the model. The Bayesian model, visualized in Figure 6, illustrates the probability of prodromal AD and mixed AD in the context of depression, obesity, and smoking in a patient under 60 years old. Initial probabilities are assigned to the respective biomarkers with 50% for APP and specific values for other factors such as metal ions, isoprostanes, and inflammation. Lewy bodies and the depression, obesity, and smoking biomarkers are set according to their probabilistic impact on the disease's progression. The provided dataset describes a Bayesian network's parameters for a probabilistic model of Alzheimer's disease focused on individuals under 60 years old who have depression, obesity, and smoking as risk factors. This model incorporates a range of biomarkers and their probabilistic values, such as metal ions, inflammation, and oxidative stress, which are linked to key AD-related outcomes like prodromal AD and mixed AD. Notably, amyloid beta, A-beta, is set with a strong likelihood value, reflecting its significant role in AD development. Additionally, lifestyle factors and genetic predispositions, age inheritance, P53, are modeled for their influence on disease progression.